So it's my absolute pleasure to introduce Dr. Jasleen Jolly, who's joining us from Australia. Not quite sure what time it is there, so a huge thanks for her for joining at that time. If anybody of you have been reading through our Look Forward newsletter, that was Jasleen was featured in one of our previous versions. So, Jasleen, if you're here with us, hi, Jasleen.
Hello, it's definitely nice and cool here.
Excellent. Well, I'm so pleased. We're kind of melting here a little bit, Jasleen. So thank you ever so much for joining us, and very much over to you. Thank you so much.
Thank you very much. I'm currently over here on a fellowship, so sorry I couldn't join you in person. But yes, if I could have my slides up, please. I want to talk to you today about some work that we published not so long ago about the power of words. So if we could have the next slide, please. It's based on a study that we did where we tried to characterize the psychological impact of visual impairment. And one of the strong themes that came out of that was around the language used around diagnosis and the impact of the journey of diagnosis. So I'm going to talk you through the various sub-themes that came out of that. So next slide, please. The first theme was the convoluted process of diagnosis. So I want to read out the various quotes from that work because I think the patient's words are more powerful than mine. So the first quote I want to share with you is, I had a few eye tests. If I'm going too fast for the BSL interpreters, please do let me know and I will happily slow down. I had a few eye tests. Nobody would ever tell me what the eye tests were related to. But eventually, after one set of eye tests in early 99, I got the letter, a 4-line letter saying that I had retinitis pigmentosa. I was below the required limit for driving, handed my license in, and that was it. So if we can just put ourselves in that patient's shoes, can you imagine what that actually felt like for that individual? The lack of information and then the abrupt nature of passing on that information. And this is a life-changing situation for them. So it's not a very good way to communicate that such a dramatic change of life situation. So we need to be a little bit more empathetic, a lot more empathetic in how we deliver that messaging. If you could advance, please, to the next quote. I was quite oblivious. I just thought, oh, well, that's probably just, maybe I'm just not very good at that particular test. And so it was a huge shock when they eventually told me what they were testing for. And obviously in the moment of diagnosis as well, that was a huge shock. So clearly we're not doing a very good job at actually communicating what we're investigating, why we're doing things, why we're repeating things. And that, I think that communicates very well to us that we need to be sharing a lot more information as we go along about what we're actually doing, why we're doing this. So that when the point comes around, it's not just such a shock to the individual. If you could advance to the next quote, please. I went to the hospital, having checks and things done, and I'd said to them, I have awful pain in the back of the eye, and they checked it all out again and couldn't find any reason for it. And then I had to go back. They made another appointment with another department and they checked through, more so at the back of the eye, couldn't find nothing. And by the end of that week, I'd lost the central vision. So again, this is about shock because no one's communicating what actually are the suspicions, what's being done, what's in the thoughts. And I know we always worry that we're going to panic the individual, but sometimes I think for some individuals, they need more information. So when the actual point comes or when the worst case scenario happens, it's not such a big shock to that individual. Next slide, please. So this is now the section about the actual impact of the words. He looked at me, sort of shook his head, and he said, "You poor, poor boy." And that has actually stayed with me my whole life. It really made me feel like it was something incredibly bad. It sort of tainted my view of the condition. So when we deliver this news in a negative way, we automatically give that individual a negative view of their condition. So, you know, the way that clinician delivered that news, "You poor, poor boy," it's a way of showing pity. And as the patient said, that stayed with them for their entire life. The kinder way of doing it would have been to deliver it factually and go, "Okay, well, this is the situation, but okay, this is what we can do to help you. Here's what we're going to do to put some factors into place." Because not only does that affect someone's way of thinking about themselves, but it affects the way they see their future clinical interactions. It affects the way they're likely to ask for help in the future, and it affects the way it affects their other relationships in their life as well. Next quote, please. He said to me, "Right, there's no point in beating about the bush. You're blind." It was like being hit with a brick. That one always hits me every time. It makes me cringe. Is this really what we're doing to our patients? Is this really how we want to treat people, and make them dread coming into it to see us? Because if that person has another complication or another problem in future, are they really going to want to come back to see us or another healthcare professional in the future if they're going to feel like they're going to be hit by a brick again and again? Next quote, please. "When I first went to the hospital, they said I had dry macula, and I went to the opticians and they sent me to the hospital. And because it was dry, they more or less said, 'Oh, no treatment, nothing we can do.' And that was it. And I wasn't frightened, but I was a little bit worried. I thought, well, I've just been left on the shelf with nothing." So we're giving our patients a sense of rejection, a sense of we don't care. And I know we don't mean to, but that's inadvertently what the message that we're conveying with our attitudes. And I know for us, we're seeing so many people that it can be quite difficult. But I think what we have to remember that people are coming to us when they're at their most vulnerable. So even though it might be an average Tuesday for us, for our patients, they've often been waiting a long time to come and see us, and they're at their most worried. So we need to bear that in mind and try and treat them how we would want to be treated when we're worried about something. And you know, we've been waiting anxiously for some answers. Next quote, please. "It was very brief, very clinical, I suppose. They literally just told me that I had this, and in time I was slowly going blind. There was no cure, and they hoped I had something new, some new treatments in probably 30 odd years." So the way I like to approach it when I see someone is like, well, okay, maybe there's nothing we can do medically, but there are lots of other things that we can do. We can refer you to the local vision clinic. We can refer you to support systems that can help you. We can refer you to the ECLO team who can signpost you as well. Let's talk about what social support you've got in place and how you can they can support you. So there's always something you can do. It's one of my pet peeves is when people tell patients there's nothing you can do, because usually they mean there's nothing we can do medically, but that isn't the truth when you look at the wider picture. So A few years ago at the Hospital Optometry Annual Conference, I did a workshop about empathy, communicating empathically in low vision care. And I've got a clip now that was recorded from that conference. So if we could play that video clip, please.
I'm presenting about empathy in low vision. The aim of this is to make people aware of the words they're using, their actions during consultations, to help patients turn a very negative experience into a more positive, engaging experience.
Bad news is really important because it really impacts on an individual's life, on their sense of self. So we really do need to get it right.
Research shows that whatever happens at that first appointment colours how that patient perceives you as a professional, as well as their entire experience of their vision loss going forward. So if you can turn something very negative into a positive experience, you actually influence how well that patient is able to adjust to their vision loss, as well as how they're going to interact with you as a professional in all future consultations.
When you lose your vision, it is a grieving process, similar to bereavement. So we have to be really mindful of that when we're interacting with patients and give them permission to express those emotions, because if you don't do that, they're not going to adjust to their vision loss and then be able to make the most of life going forward.
Don't belittle people's worries. The patient has genuine concerns. Listen to them, respond to them. My pet peeve is when practitioners tell patients there's nothing we can do, because there's always something you can do. It might not be medical therapy, but we can refer people to support networks, to helplines, to charities, to local groups.
You can provide them with low vision aids or advice. You can put them in touch with support services, give them a helpline number, get access to counselling services. You know, there's all these other things are still treatment, they're still helpful. So it's really important that we don't send patients away feeling completely hopeless.
Give people hope. Don't give them false hope, but give patients hope, because without hope, the human spirit just can't survive. A lot of my patients have previously also told me that when they first got their diagnosis, they were talked over, especially if they were given the diagnosis as a child. So the clinician would then speak to the parents or accompanying carers, and the patients get really irritated. So engage with the patient. Even if they can't see you, talk directly to them, because they'll be able to perceive that and understand you better.
And sometimes referring to current research, things that are happening, even if it's not directly relevant to that individual, it just lets them know that people do care, they are working around them. And a lot of this is around making people feel that someone does care.
Be empathetic. Think about how you would feel if you were in that situation. Always ask and engage the patient so that they feel included as part of that consultation.
It's always so cringeworthy listening back to your own voice. So I just want to highlight there, empathy is not the same as sympathy, because sympathy can come across as very false. So being empathetic is trying to connect with the individual and trying to relate to what they're saying so that you can actually support them. So if you can't understand what someone's going through, say that. Don't pretend that you can. And then the final theme that came out of the work on the diagnosis was the search for information. So this quote is, "I recognize the consultant may not be able to spend all the time you'd want to be talking about it. So what they should say, you know, here is a brief explanation, take time to digest it. Here's a leaflet, I'll pass on your number to this organisation or someone within the hospital or support team, and they will call you to discuss with you in about a week or so. I don't need to speak to a consultant or someone that's an absolute expert in their field. Sometimes you just need to talk to someone to explain, you know, that it might be a year, it might be 50 years. So, you know, people always imagine the worst case scenario. And I think a lot of the patients felt that they wanted to understand that there was a lot of misconceptions about what is blindness, what is visual impairment. We see this in the general public. Well, actually, this was also there in our patients at the beginning of their journey, and what the natural history of their condition is and how it varies amongst different patients. People wanted to know that information, but they couldn't necessarily take that on board immediately when they first saw someone. So having access to someone like the eclos in the hospital system was really helpful, or even optometry at their optometrists later on down the line. Next quote, please. I do think it's a really crucial part of someone's journey with this condition or something else. I think that first hour when you found out, I think that can go a long way to helping you in the future. It's hard because it would have been nice to have someone say to me at that time, look, it's not the same for everybody. Some people will be completely blind by the time they're 25. Some people keep their vision until they're 60. I didn't know that. All I knew was that you have this condition, you're going to lose your vision, and we can't tell you when. So that fear factor and the fear of the unknown was a theme that came up time and time again, not only in the diagnosis, but also in some of the later work that we did. And all this uncertainty seemed to mar people's life journey quite a lot. And we never talk about the uncertainty in clinic. And that's something I think we need to get better at tackling and talking about. Next slide, please. Next quote. If it had been explained to me a little bit more about what it actually was, I mean, I had to come home and look it up on the internet, really, find out what was actually going on. And as we all know, the internet can be the worst place to look things up because often a lot of scaremongering happens on the internet. So in the low vision clinics, I often try and direct people to reliable sources of information. So I give them websites that I think are better sources of information and steer them away from just random searching. But we need to try and be mindful of doing that at the point of when we tell them what's going on, because otherwise people can get into panic mode if they start seeing the worst case scenarios or even the wrong information online, as you'll see by the next quote, please. When I looked online for that retinal atrophy, I found it's the sort of thing that dogs and cats get. I don't really know what that means, but it doesn't look very good. So I'm guessing this patient found something about toxoplasmosis, and maybe it was related to what they had, maybe it wasn't, who knows. But they panicked and didn't really understand what was going on. So, and yes, clinic gets busy and we can't always explain, but also if they've not got anyone with them and they don't really take on what's we're saying and we don't have the right leaflets, it can get very difficult. But I think that's where the support services, having charity desks, having the ECLO team in the hospitals becomes so important, because there's clearly an information disconnect between what the patients are taking on board and what we're giving them or not giving them. So that was, and you know, some of these patients had been seen 15, 20 years ago, and yet they were able to recount their diagnosis journeys as if they were yesterday. That's how marked the effect of those words were. Like the person who said they felt like they'd been hit by a brick, that was 12 years ago, but it was that stark for that individual. So it really, even though it's a small moment in time, it's really that big an impact on that person. So that's why it's such a critical time, because that then influences the rest of the care, influences someone's self-esteem, and it influences how they then interact with others, how much help they're willing to ask for, how they see themselves, like, are they a burden, are they willing to embrace the visual impairment. We've just submitted a paper on how people make decisions about whether they're going to be visible about their visual impairment, or whether they hide it, and how they have to go through that process of making those decisions lots of times a day in many different situations. And the impact around diagnosis actually does feed into all that decision making because of the trauma of it. So it has such a long-lasting impact. Next slide, please. And then following on from that work, we've actually gone on to characterize many other aspects of the psychological impact of vision loss, because if you look at there's not very good support, psychological support for visual loss. And if you look at many of the programs that have tried to tackle it, they don't have a very good success rate, because the standard CBT programs don't actually tackle the thoughts and feelings that come as a result of visual impairment. So we wanted to characterize what actually comes out of vision loss, so that we could then hone in and design something that's far more specific. So that's the next stage of the program that we're working on. Next slide, please. So just to conclude, our language does matter. I think as healthcare professionals, we do need to start incorporating better empathy training in what we're doing, both at student level, but also at professional level. The impact of our words is long-term, and it gets compounded by future interactions. ECLOs are invaluable and need to be used far more effectively in the hospital system, and possibly even wider. We need to work with our patients when we're communicating with them, and communication is just so critical. It's not a soft skill as it's often termed. It's such a critical skill, and it can be learned. And please, let's not hit our patients with a verbal brick, because they are the heart of everything that we do. And with that, I'll stop and take any questions.
Yeah, we have got one. Jasleen, I hope you can hear me.
Yes.
Hi, it's Kate. Just a comment, actually, that's come in, a comment and a question. So somebody said, I have RP and my consultant told me I'll be completely blind by the time I was 30. I'm 31 and still have very good visual acuity and functional central vision. Those words will always ring in my head, even though they haven't turned out to be the truth. So I thought that was just quite a nice comment to follow up from your talk. But a question.
Thank you for sharing.
So a question is, if I'm interacting with somebody many years after their diagnosis, is there anything I can do to lessen the impact of a negative diagnosis?
Work with the patient, I would say, and find out where they're at, how they're doing. Find out what they need, what the gaps in their knowledge are. I tend to always ask, how is someone doing? What kind of social support they have? How are they coping? What can we do to support them? Do they have practical difficulties? Where do I need to signpost them? What do I need to fill them in on? Because it's surprising how many people don't know about fairly straightforward things like access to work if they're of working age, or there's quite a lot that's available out there Even things like someone who's really fond of hiking. There are companies that specialize in hiking holidays for people who are visually impaired. Can make a huge difference to someone's quality of life. Gardening tools for people who are visually impaired, knitting tools for people who are visually impaired. Little things like that can make a big difference.
Thanks, Jasleen. Matt is telling me that time is up. So thank you very much. And thank you so much, Jasleen, for joining us from Australia.
My pleasure.
I love a good conversation. I love the questions. It's a really, really important part of the day. So if you do have any questions that we've not been able to ask Jasleen, please pass them to a member of the team, and we will then pass them on to Jasleen and come back to you specifically with an answer for your question. So we have got a really, really packed program today, and obviously we want to try and get through it so you guys still get your breaks and bits and pieces, because we know you like your networking, which is something you've told us. I'll be saying that quite a lot later on.